What's up, y'all? Happy Friday. Today is a very special day. It actually is objectively a special day, and I would love to actually pass the mic to our Teaching Points guru, Khashayar, to tell us why today is a special day.
Hi everyone, I'm Khashayar, medical student from Iran and one of the CP Solvers Academy members. Tonight is Yalda, the longest night of the year. It's a special celebration here in Iran.
A special celebration indeed. Thank you, Khashayar, for continuing to crush the Friday scribing. I'd love to, in the spirit of acknowledging all the people who are making this happen, also pass the mic to Manahil, um, for her to introduce herself and share what you're up to and what your role is today.
Hi everyone, I am Inahil. I am G from Pakistan. I will be doing scribing today and very excited for Franco Kids.
Franco, indeed. Franco Murillo, known him for many, many years and many Aldas. Franco, before you tell us about your case, why don't you just reintroduce yourself to the VMR crowd and update us on where life is taking you next year?
Hi everybody, I'm Franco. I love clinical reasoning. For whoever knows, I've been like GP Solvers for a while. I'm currently in internal medicine third year, but I'm going to Seattle this summer for my room
Woo!
fellowship. Yay!
For those of you that don't know, Franco has been part of CP Solvers for many, many years, over 3.5 to 4 years now. He was actually part of the first group of people who was coming to the US with CP Solvers being involved in his life. And it's really cool to see him now being in a different phase of his life, being a rheumatology fellow, teaching us and enlightening us. If you guys are inclined to get to know Franco better after today's session on YouTube, you should check out 2 Mondays ago. He presented an unbelievable rheumatology case. But it's also special because you see somebody next to me. My work husband, Reza, is unavailable. So my real life wife is here to discuss. Do you want to tell folks about yourself?
Can I change the theme song
Sure.
for today?
Yeah.
Is it Kara loves Rob? Rabih loves Kara. It's the best. Actually, it's not a palindrome anymore.
It's not a palindrome.
It's KLR.
For those of you who have no idea where that's coming from, that is the theme song to RLR, which is part of what CP Solvers does. But yes, I love it. It's not a palindrome, but it is
Truer.
truer. Yes, truer. I was so hesitant to say that out loud on a recorded tape, but I don't think Reza's gonna watch this, so I
It's
think
his fault for not coming today.
exactly right. So tell people about yourself.
What? Oh, I like plants. I want to take responsibility for all of the plants that
No, you're ruining my facade.
I am Rabih's wife and Nar's mom first, and I will be a rheumatologist next year second. Yeah.
She is unbelievably brilliant, incredibly smart, and all the things that she just said. I would say those two things are first, but I think what the CP Solvers Academy members will know her for is her unreal commitment to being the best doctor version that she can be. And yes, I'm very biased. We have been together for a long, long time and we'll be together forever. But I think the real reason she's here is not because of that. It's because of how brilliant she is as a doc. And so I think she can, in fact, fill Reza's shoes, maybe not with as much clinical experience and exposure, but with the same degree of commitment to being the best version of herself, just like we know and love Reza to be. So I think it'll be especially fun since the odds that Franco will touch rheumatology. Who knows if the answer is rheumatologic, but I think Franco will touch rheumatology nonetheless. So we'll have a ton of fun. Are we rock and roll?
Yeah.
Okay. All right, Franco, the mic is yours, my friend.
Perfect. Okay. So the chief concern is rigidity and shortness of breath. For the HPI, this is a 55-year-old male who was discharged 3 weeks ago from the hospital. At that time, he presented with fecal impactation and dehydration. He was discharged after regularization of the bowel movements and hydration. He was discharged with an extensive bowel regimen. However, 1 week after the discharge, he started to have global rigidity and tremors. At baseline, he was able to move 4 extremities, but he did have a mild tremor. He was also gradually becoming more nonverbal. He was only saying one-word phrases. And then 2 days before admission, he was unable to eat because he was unable to open his mouth. He saw his PCP before the admission, and the PCP note said that he noted marked stiffness and difficulty holding things. The PCP thought this could be adverse effect of a risperidone prescription that he had been lingering around for a while. So he DC'd the risperidone and increased a benztropine dose for him. Because of the worsening of the stiffness, he came to the hospital. And while he was in the ED waiting to be admitted, a rapid response was called due to acute hypoxia and quote unquote dystonic movements per the nurses. He was noted to have SpO2 down to the 80s and improved with 5 liters of oxygen. And then he was admitted to IMC. I gotta stop there.
Holy smokes, Franco, what an incredible start. Maybe I can just ask one clarification question, which is, do you mind reminding us how old the patient is? Heard
55.
55. Yeah, I'm really curious, where is your mind starting? It's such a large amount of data.
I know. I mean, initially, I think my brain goes in two different directions. As a resident, as a third-year resident, I think often very much the way Mengi was describing when she was talking about her case yesterday as a triage situation, and that like oftentimes walking into the room on a rapid response, you want to go down like a hypoxia differential. And so holding space for hypoxia side of things in my mind. And then on the other side of things,
It's okay.
okay. And then on the other side of things, trying to also work out
what happened here. Something. Can you guys hear us okay?
Yes.
Okay, yeah, I'm sorry.
Okay,
Sorry.
no worries. On the other side of things, thinking about the way that like the underlying problem that could potentially be driving the hypoxia as a diagram being like neuromuscular, something neuromuscular that's ongoing. And so let me think about that first, and then I'll kind of think about the hypoxia. It's interesting. It seems like this is a subacute, potentially progressive course, and that is predominated by rigidity. But the reason why I bring up a potential neurologic component to it is it seems like there's autonomic dysfunction on top of that, and that like this person seemed to have been significantly constipated, not responsive to a bowel regimen, and driving the smooth muscle like peristalsis of the colon is like an autonomic nervous system component to it. Seems like almost there was also a component to it. It seemed like there were maybe some bulbar symptoms that had initially presented after the tremor earlier on in the course. So like maybe bulbar symptoms, maybe autonomic dysfunction in the colon, and then the skeletal muscle rigidity as well. So kind of hitting like all components of the nervous system, and this like just these dystonic seeming worsening rigidity in his skeletal muscle. And so I don't have a great like initial like I don't want to hone in on a specific diagnosis in this, but like keeping in mind that like demyelinating disorders can look kind of like this, the Parkinsonian spectrum disorders with the tremor can look like this. And then the fact that I don't know what he's taking the risperidone for, but risperidone as a dopamine antagonist, causing like severe things with autonomic dysfunction like neuroleptic malignant syndrome, keeping that in the back of my mind as well. But like most of me wants to like get a good neuro exam, actually feel what the tone is like, see if there's catching, see what the tremor looks like. And I would be able to do a lot of those things on initial screening neuro exam when I step into the room with this patient on the rapid. And then kind of on the hypoxia side, you know, it seems like this person has an escalating oxygen requirement, making sure they're protecting their airway and that they don't seem to be needing escalation to something like intubation, with non-invasive positive pressure being potentially dangerous in this person if they are not able to protect their airway with the positive pressure, doing a cursory volume exam to make sure that there isn't a water component to this, and, you know, checking on the rest of the vitals to like think about whether other things are filling the alveolus. But then the overlap between those two big categories being that like there's some kind of underlying like neurologic dysfunction, that maybe the diaphragm or diaphragmatic weakness that is causing this hypoxia.
Yeah, no, I love that. I think that like you clearly are starting with the idea that like the hypoxemia is an end-stage manifestation of the neurological dimensions of this case. And I think if you take a mental shortcut of asking yourself, like, how is the cardiopulmonary apparatus influenced by neurological dysfunction? And while you can have autonomic disease impact the heart in the form of autonomic dysfunction with flash pulmonary edema, it's much more common for the lungs to take a neurological hit, often through the form of aspiration, but more esoterically through the form of diaphragmatic dysfunction. And I think that's probably what you're going to be thinking about, as you said in the first few seconds of this. And I would just say, like, you ask yourself, like, what other devastating complications can you have from a tremendous amount of rigidity? And that's probably what you're going to be forced to study initially because of how sick this person is. And the other big one is this person's been so rigid and so stiff for so long. They've generated so much metabolic activity that they're hyperthermic or febrile. And so the other thing that I'm looking out for, in addition to really localizing where the hypoxia lands, is it pulmonary edema? Is it aspiration? Is it ventilation issue with diaphragmatic dysfunction? Is open to the other complication of rigidity, which would be hyperthermia, which actually might even afford a diagnostic clue and say, hey, the rigidity is actually a primary muscle issue. So I think if you're walking into this rapid, it's very unusual that you care a lot about a temperature in a rapid, but this is one of those circumstances where I think I'd probably pay attention to it and would not assume that it is aspiration pneumonitis or a pneumonia, but maybe something else. So I agree with you. I've never seen this in real life. I've seen a few cases where rigidity is the center of gravity, which it seems to be here. So I'm so excited to learn from both of you. But I think realistically, we'd probably have to think, is this person protecting their airway? And do we have to go down hyperthermia management given how long he's been stiff for?
And there's a quick, like, I feel like a helpful point of care test is that like most people have a point of care VBG available to them to like determine whether there's a ventilatory component to the hypoxia.
Franco, I now see why we're doing this on a Friday. I'm very intrigued. Thank you for such an interesting case. Excited to learn a lot from it.
Yeah, perfect. And basically everything that you have discussed so far was also kind of like in the back burner when I was in this rapid. So prior medical history. The patient has autism spectrum disorder. At baseline, he was minimally verbal. History of psychosis. And there is an admission for the fecal impactation and dehydration. Medicines, he was on risperidone for the history of the psychosis, but was recently stopped 2 days before admission. Venstropine, the current dose, it was 1 milligram BID. They increased the dose at the same time that they stopped the risperidone. Miralax, Dulcolax, and Trazodone. Family history, the father has prostate cancer. Social history, none. Allergies, none. And no health-related behaviors. Vitals, temperature 38.5 Celsius, heart rate 140, blood pressure 140 over 90, respiratory rate 25, SpO2 95% on 3 liters. So a little bit of the physical exam. For general physical exam, he was lethargic, cachectic, he was grimacing, and has profuse sweating. Cardiovascular, tachycardic, but no murmurs. Pulmonary-wise, continuous air transmission, no crackles, no wheezing. He gradually improved with the oxygen, with the 5 liters. We were able to decrease to 2 liters. Abdomen, rigid but not tender. He did have bowel sounds, no visceromegaly. Neurologically, not following commands, global stiffness in all the muscles, also in the neck, also in the abdomen. He did have the left upper extremity was held in flex position all the time with tremors. I wasn't even unable to extend the left upper extremity. Wow. The rest of the extremities were extended, but rigid globally. The skin was really dry. And I think I can stop there.
Franco, this is unreal. I think I literally feel like I'm in the room. Such an incredibly detailed physical exam. It really brings the patient to life. Maybe before we analyze the exam, I'm curious, did anything stand out to you in the context and the medical history and whatnot that you made note of?
I think it seems, well, I'm curious as to like he's on serotonin,
Yeah.
serotonergic like inhibition, or sorry, serotonin reuptake inhibition. Because I think it's hard for me not to put in the context of the exam because to some extent,
Yeah.
like med history, I was paying really close attention to the med history.
Yeah.
And then, you know, it doesn't seem like it seems like he's on these medications primarily for psychiatric concerns.
Yeah.
And oftentimes I worry a lot about the side effects of those in the context of somebody having a lot of titration around their psychiatric medications.
Yeah.
And that's probably as far as I was
Yeah.
thinking with
Yeah.
that.
Yeah, the hole that it plugged for me is to ask the first question from how this case really began was, how is this 55-year-old man going to the ER for impaction, right? And I think that was a void. And I just wanted to make sure that actually it wasn't a progressive autonomic disease or some sort of systemic illness that would explain why somebody's all of a sudden impacted. So it was really interesting to see like what medical history we were given. I think the medical history we were given really lines up with a rigidity spectrum disease, which is why you're so inclined to the exam. But I think the fact that this person is minimally verbal, probably doesn't eat that much, I think readily explains the constipation. So I think we're no longer in a situation where we have to dive deep into the fecal impaction. I think we can probably put that aside temporarily and focus on just the other two elements, which is rigidity, psych history. So I think it's very reasonable for somebody who has this condition, who's not eating and drinking much, to get constipation.
I see. So instead of like fecal impaction as a driver of the underlying or the overlying syndrome, like maybe as a consequence of something else that's happening. Okay, that makes sense.
You could easily put it to say, hey, there's something that unifies a relatively young person getting constipation, rigidity, and whatnot. But I think you can park the constipation aside because it's such almost an expected phenomenon for the things that are going on otherwise. Fair?
Yeah, that makes
Awesome.
sense.
What'd you do in the exam?
I mean, I would be pretty concerned about this being like an emergent, like one of the emergent syndromes secondary to either overdose of either the serotonergic medication or the significant like after effects of dopaminergic blockade. But it's interesting because he stopped the risperidone 2 days before the admission, which rigidity would line up more with that, with an overdose of that as opposed to underdosing that and him tipping more into the psychotic spectrum of things. It's interesting. It's almost like viscerally somatically overdose of these medications seems to cause more visceral somatic things. And then if you underdose it, you end up on the psychiatric spectrum. But it was interesting. The dry skin and the sweating, I was having a hard time reconciling, and that like seems like there's a cholinergic component to this if there's a lot of sweating. And like I guess rigidity, but it's not like he's taking medications that have a strong cholinergic component to it. This is an area of thinking that I'm not very I guess familiar with or experienced with.
Right. It's amazing how you like, I think realistically speaking, what can you do in the heat of the moment, or literally the heat of the moment, or without being a toxicologist, is I think that your job when you see this patient realistically is to say, hey, this is tox, right? Or this is medication induced. And I'm curious if you're medical students who are at the bedside, like how would you distill, like you're authentic in saying, hey, I don't know if I can be more precise than that label of med and tox, but how would you distill that instinct down to somebody who doesn't have that experience? How would you explain to your MS3 that this is probably a med thing? Or a toxic?
Ooh, that's a really good question. I feel like I'd have to think about that before like describing it to them. But I would say like the kind of acute progressive onset in the context of taking psychiatric medications that have known emergent like syndromes that involve like hyperthermia and rigidity and like autonomic dysfunction. This patient kind of aligns with that illness script that I have in my mind, and it might be becoming more familiar with those illness scripts, but also that like, you would expect somebody to be who's septic and febrile to be like hypotensive or have a more definitive localizing initial like source, as in like it was very clear that they had an aspiration event, could still be something that's ongoing underneath, or like had a different first presentation. I'd say like if there was a septic source, it would be most likely gastroenterology, like in this patient. But yeah, I think like the fact that there's hypertension, there's fever, there's rigidity, and then there's like this potential autonomic dysfunction of like profuse sweating would make me more worried that we are modulating something about their autonomic response as opposed to them having an appropriate.
Love it. That's awesome. I'll definitely like try to take it as much as I can with the tox element, but I think you're on a roll here. So why don't we explore what do you think you might do if you were in this moment in terms of any empiric treatment things that you would query? You may not know with confidence, but that you would wonder based on prior exposure.
There's a way to reverse neuroleptic malignant syndrome, right? I can't remember what it is off the top of my head. I would look that up. Awesome. Or I would ask somebody nearby what that is.
Hello.
Hi.
I'm nearby.
Attending. I know that I potentially need to reverse this one medication to it.
By the way, I love that her phones are like from 1980, you know, the ones that you hold like this. Hello.
I had a cell phone that was like a flip phone when I was 16.
My mom bought it for me.
Oh.
Okay. So that, and then what do you think laboratory wise or diagnostic wise would help you a lot?
I mean, I would definitely want, like, I would want a VBG. I would want a lactate. I'd probably, if I were like expanding my laboratory workup, I'd want like a TSH and a CK and like a CMP, I think. CBC, sure. Yeah.
I think a CK is huge here, and I think a TSH is a very wise idea. Yeah, I'll just all I can really offer is just a deeper dive into the tox realm, and I think the other angle you could suggest to toxidrome is just to remind yourself that we really worry about fever representing infection, but there are 3 other H's that we want to think about on day 1, and the 3 other H's are hormones, hyperthyroidism being the lead example. The other H are hematological conditions, such as a transfusion reaction. You want to recognize that right then and there, or acute leukemia, or TTP-HUS. And the last H is hyperthermia. Hyperthermia is a very unique entity where the temperature is going up, not because of cytokine-mediated elevations in body temperature, but excessive exposure to heat or impaired dissipation of heat. And what hyperthermia fundamentally means is the body is no longer in control of the temperature at which it exists. And no longer is it mediated by cytokines, it is mediated by too much energy generation or too little dissipation. And I think the exam here supports features of both, with most of the time where there's too much energy generation, it is being generated by the muscles. And imagine if you are exercising and running so much so and you cannot cool off. This is what's happening to this patient by virtue of rigidity. The way we would be able to support and really confirm that this is hyperthermia is to see what the temperature curve looks like, and it should not budge at all and should be unaffected by Tylenol or any NSAID. And I think at that point, you'd be able to be really confident this is hyperthermia. And when you are in fact dealing with muscle activation that's so pathologically high, it is almost always drug induced. There's really very few infections that do this. And I think the one to keep in our mind is tetanus, though the distribution and the time course of tetanus is not in keeping with this kind of syndrome. There are also some antibody-mediated diseases that can cause rigidity, but I think we'll only really talk about those later. And so I think when you think of this, you really should think of, I would say, of 3 different things up front. The first is serotonin syndrome. The second is neuroleptic malignant syndrome. And the third is actually sedative withdrawal. So this is actually a classic presentation for baclofen withdrawal as an example. And so in addition to paying attention to what the patient is taking, we have to pay very, very close attention to what the patient is no longer taking. And baclofen withdrawal is a very, very life-threatening mimic of serotonin syndrome and MS, and is easily missed if you don't query the prior medication list and only focus on what the patient is taking now. A good general early treatment to keep in mind for all three conditions is actually benzodiazepines. So dantrolene is a really good treatment antidote specifically for neuroleptic malignant syndrome, but it's actually further down the algorithm. So this is somebody who, despite being confused and altered, you might actually give benzos. I'm going to try to see how far we can take this. Okay.
How far we can I ask one question?
Yeah, for sure.
How,
Yeah.
so if we use Tylenol as an empiric kind of treatment to diagnose, how like fast would you expect, which is, I feel like I should know this, but how fast would you expect somebody's fever to come down as like in response to that? Like,
yeah, I mean, I don't know. I think probably an hour.
okay.
Yeah, and if it's still elevated in an hour, in fact, if you don't do anything else but give the patient Tylenol, the fever is only going to go up.
Right. Do you, right. And so do you have an hour to figure that out?
No, I think you really you're gonna try to to reduce the fever with Tylenol in the circumstance, but I think the combination of temperature and rigidity should make your default hypothesis hyperthermia.
That makes sense.
Yeah.
Okay.
Yeah, I don't think you need the Tylenol, but it's just another clue that you'll probably accumulate. Yeah.
Okay, what were we gonna do? I interrupted you.
Remember, I'm glad I remember. I almost forgot. Remember how Frankel was like very vividly saying he was holding his arm out, left arm, in a very fixed posture.
And then the other one.
Yeah. So this is a leap. We might stumble, but we'll see. Psychosis.
Yeah.
Fixed posture.
Malignant catatonia.
Okay. All right. Franco, mic is yours. We'll see where we go.
I'm loving this. Yeah. So let's see some labs. CBC, hemoglobin of 9, that's his baseline. MAC 85, MCV 89. White blood cell count 11K, platelets 121. Creatinine 2.7, up from his baseline of 0.5. DON 123. Sodium 166, potassium 5.2, magnesium 4.3, calcium 8, albumin 4.3, AST 61, ALT 40, normal bilirubin, a negative UA, no RBCs, no WBCs, no bacteria in the UA. Lactate 2.5, CPK 900, TSH and T4 within normal limits. BBG, the CO2 on the BBG was within normal limits actually, and the pH wasn't that altered there either. CT head, unremarkable. EEG, unremarkable. CT chest, unrevealing. CT abdomen and pelvis, a rectal sheath hematoma, 4+4 centimeters. Neurology was consulted, MICU was consulted, and they decide to upgrade the patient to MICU with concerns of neuroleptic malignant syndrome. They give dantrolene, but the stiffness didn't improve at all after dantrolene. And at that time, I think I can stop. And the next aliquot will give the diagnosis.
Oh, wow, Franco. I'm just so intrigued by this case. I've never seen anything like this in real life, so I'm really excited to reflect with you. What did you make of the BNP, the basic metabolic pen?
The BMP.
Yeah.
So was sodium really like on the 160s?
Sodium was 163, I believe, and the BON was over 100. Creatinine was 2.7.
I mean, it just seems like this person's either incredibly has had long-standing kind of insensible losses, or I mean, like, I feel like my differential, I'd probably hold another sodium because the K could be a little elevated from the renal dysfunction. But the hypernatremia is like insensible since like DI. In my mind. And then just that I guess if you have significant rigidity, a super elevated CK, can you get cell death and I mean, this patient needs hydration, like
Yeah.
something to relax
Sure.
on the sooner side is the instinct that I would get from that, but I don't have a well-formed thought
Yeah.
diagnosis around that.
Yeah. Let me ask you this. What were you expecting the sodium to be, honestly? What did you think it was going to be?
Well,
Yeah, right? You thought it
low.
was going to be either normal or low. And why did you think that?
I don't know if this person's been hypovolemic
Yeah.
and like
Yeah.
has like an AKI and
Yeah.
like I probably would expect maybe like a component of hypovolemic, like hyponatremia,
Yeah.
and like aldo to be activated.
Mhm. Yeah.
That's where my mind would have
Yeah.
gone.
Yeah. Awesome. Who in your clinical experience, if I tell you, hey, I have a patient who's hypernatremic, how old would you guess they are?
Very, very old.
And why?
I feel like usually that it's like I feel like I've seen it most often in the context of like insensible losses or like somebody's on a vent or in the ICU.
Right.
So like critically ill or like older.
Yeah. What's the difference between all the older patient and all those, because all those things can happen to younger people.
Right.
What is it about the older person that makes them vulnerable to get the hypernatremia?
Ooh.
The
No.
vulnerability in their thirst.
Oh.
So you should never, ever get hypernatremic, no matter what is going on, as long as you have three things: access to water, an intact mental status, and an intact thirst mechanism. And the thirst mechanism is so bad and so strong that it's almost impossible, though happens and unfortunately many parts of the world happens, but it's almost impossible to fall asleep thirsty. You can fall asleep hungry. It's much harder to fall asleep thirsty. And so when you see a sodium of 166, the first thing that we all ought to analyze together is we know for a fact that this patient is having water loss. But the more important question is, why are they not keeping up with that water loss? And their loss of either access to water, ICU, ventilator, or mental status. And for me, this tells me that this person's cognitive status is really, really poor. And the question is that part of the chronic phenotype and in keeping with the phenotype that we mapped onto the poor PO intake, poor water intake, constipation signature? Or is this actually a clue that this disease has been going on, this process has been smoldering for some period of time? And so I now worry that the syndrome is older than what the patient reports it to be, because I have a very hard time imagining that the time course is on the order of days to get to a sodium of 166.
That's fair.
And so I think it allows us to say, okay, your DDX initially was serotonin syndrome, neuroleptic malignant syndrome, malignant catatonia. How do you think we can go about sorting those things in terms of the time course they develop? Do you have a sense of what happens fast, what happens slower?
Well, I love how, because like I feel like earlier in the discussion I was talking about how like decompensated psychiatric disorders are often like on the more positive side of symptoms, and I just completely forgot the entire category that you can have like severe negative symptoms that result in a very, very similar presentation. I think the acuity of serotonin syndrome and neuroleptic malignant syndrome, especially with the clue that the hypernatremia potentially indicates a much longer, potentially smoldering course of altered mentation and lack of response to like reflex, like basic reflex, thirst reflex, would make me a little more worried about malignant catatonia. And then in addition, which is funny because I've seen it at the general, but I feel like the other side of it being like he didn't respond to the initial like dantrolene. So, and we know that he's been off dopaminergic medication for the last 2 days, and this potentially represents more of a rebound from inadequate treatment of his psychiatric concern as opposed to a side effect of overtreatment of his psychiatric concern, and wouldn't resolve with dantrolene and would require a trial of benzodiazepine.
I love it.
Yeah.
I love it. And let's just, I'll share some reflections too. I'm just curious to get your take on what you think about a rectus sheath hematoma. What does that mean to you, and why do you think it happened to this person?
No idea, but it sounds like potentially local trauma. And if local trauma, like just like significant
Awesome.
progressive
Awesome.
constipation.
Yeah. I think that, so a rectus sheath hematoma, just to reflect on that briefly, a rectus sheath hematoma refers to hematoma in the muscles, right around the abdominal space, right at the superficial, between the, separated by a linea alba. In the vast majority of patients, it occurs in patients who are on anticoagulation. It can occur spontaneously, and while I have never seen it, I can easily imagine the sheer muscle tension and contraction causing rupture of blood vessels, resulting in the hematoma. It can bleed quite a bit, and I have seen 2 cases where IR had to embolize ongoing bleeding from rectus sheath hematoma. But I'm glad that his hemoglobin is normal, and I think it would be really, really important in this patient to use a Foley catheter, which you probably will have, to measure his bladder pressure to make sure he's not suffering from abdominal compartment syndrome. I think that if we were to sort of rehash the journey that we've taken so far, we have a patient who's febrile. And the source of the fever is not mysterious. It's the sheer amount of clenching and tension he has in his muscles, generating hyperthermia rather than fever. And so I think this case really boils down to, why is the patient's muscles really, really stiff? And I think that probably the most morbid diagnosis that people see worldwide is tetanus, where you have periodic superimposed spasms. And the lack of superimposed spasms is an argument here against tetanus, and an argument against some antibody-mediated diseases like stiff person syndrome, which is where I thought we would go, because Franco is a budding rheumatologist. But I think that's a little bit less likely when you're not having superimposed spasms. So I think you're here in the realm of worrying that this is drug-induced. And serotonin syndrome actually has a very fast on and offset. It's usually hours or a day at most, and starts to improve pretty quickly. The other features here that are not present for serotonin syndrome are myoclonic activity in the lower extremities usually, and potentially changes in the eyes. Neuroleptic malignant syndrome is a very good thought, because it actually can be a little bit slower, sometimes days or weeks into the syndrome. But I think the fact that the medication was discontinued and the patient continued to progress may have just meant that he has really severe neuroleptic malignant syndrome. It's interesting, many patients with NMS have iron deficiency on their blood tests, and iron deficiency is felt to be a risk factor for it. So that might be something that you do. But after you start to think of, if there are holes in your drug-induced hypothesis, be it serotonergic drugs, dopaminergic drugs, dopaminergic receptor blockers, or baclofen and other sedative withdrawals, you have to start to think, could this person have malignant catatonia? And malignant catatonia often is a prodrome and an extension from another psychiatric condition. And I honestly will say that it really is Franco's very astute observation of his left upper extremity being in a fixed posture that raises that suspicion. So I don't have a tremendous amount of confidence in what the answer is, because this is not something that I've either read about or discussed or seen frequently. But I think if I were stuck on an island by myself, I would be rushing towards the benzodiazepines in this patient. And so I really just want to learn from Franco to see what his experience was like and what he did. But any other thoughts before we pass the mic to him?
No, I think I'll save them for the when we reflect.
Sure.
I'd love to hear from Frank.
Franco, what was it like what were you thinking in this moment, and what happened next?
After the dantrolene didn't work, we were like, okay, we don't know what to do next. We need to kind of like gather, redo the whole history, try to find another possibilities, but at the same time treat him, because he was actually having this stiffness that was without control and having definitely an effect in his oral intake, his vitals, his temperature, everything. So it was kind of like time rushing. So with the help of neurology, we kind of like review everything. And we decided to actually give him Valium. Valium improved slightly the stiffness. And then he started having a combination of stiffness and spasms. So at that time, neurology wanted to do an LP. ID wanted to treat empirically for meningitis because of the neck stiffness as well, although there wasn't like kind of like infectious kind of like process, high in the differential. He got empirical treatment for meningitis. The family refused the LP. Neurology tried to do nerve conduction studies and EMG. The nerve conduction studies didn't show any polyneuropathy. They didn't complete the EMG part because of the hematoma, and they were at risk of having more hematomas because of the muscles that he has having this stiffness. They sent the GAD65 antibodies, and they were in the 2000s with a normal value of 0.5 up to 5, because he was still having a little bit of spasms and stiffness, although gradually improvement. And he also have these the volume doses that he was getting was so high enough to the point that he was really sleepy all the time. So they decided to stop the volume and start him on IVIG with these high levels of GAD65 antibodies. And the IVIG improved to the point that he was able to open his mouth. We were able to take the NG tube. He was able to come back to baseline. And then he was restarted on volume at lower doses after the acute period happened. And the diagnosis was stiff person syndrome. So yeah, there was an autoantibody involved.
I think it's profoundly important, and I don't think we have time to reflect on it today, but when you mentioned that he had superimposed spasms, I can't emphasize how that is actually not in keeping with NMS, serotonin syndrome, malignant catatonia, and the combination of stiffness plus superimposed spasms is a very unique world. And I think that once you saw that, I think you can get a lot of momentum towards a condition that doesn't exist, chronic tetanus, but if you saw it in acute form, you would be worried about it. And I think this is Celine Dion's story. She suffers from stiff person syndrome, and I think I learned a lot about this condition from her story, and I think it was amazing that it showed up in such a hectic, devastating way. And I'd love for your reflections on that, Franco. But I'm curious, Kara, any reflections on your end before we learn from Franco?
Oh, I think, I mean, I have to read about stiff person syndrome because definitely not something that I think about at all, but something that I should now moving forward. I think really my big takeaways from this are, I mean, this is why I love you, but like your ability to take things like a laboratory panel and tie them to a time, like be able to give you clues towards a time course, I feel like is also what really underlies a lot of framing the problem in this patient. And that like understanding that this is like a chronic progressive picture as opposed to an acute rigidity helps differentiate like how we're approaching like acute causes, like a side effect of a new medication start, or like a trigger that could cause tetanus or something like that, as opposed to like a chronic progressive disease that may have been slowly building to its culmination, which is when we meet the patient. And then being able to take that in the context of potentially like not being on the right medications or stopping the right medications in malignant catatonia versus like investigating for a kind of chronic progressive autoimmune physiology.
Beautifully said. I think that Kara's thoughts are very much captured here. I'll just share this with you very quickly about the time course. And I think when you have acute rigidity, you presume it's acute, and you look at medications and infections. And as soon as you get a hint that the time course may be more subacute or chronic, here maybe the hypernatremia, but I think practically speaking, the fact that it doesn't improve with treatment gets you into a whole different world. And SPS is probably the most common cause in the spectrum. But Franco, I imagine you've been deep in this world. I'd love to get as much juice as we can out of your experience and what you learned.
This was really a challenging case. I also saw the Celine Dion documentary after, and it was like mind-blowing. So it's highly recommend that one. So the fact of this patient having all these, the fever was kind of like a big takeout there. Is this true fever, or this the neuroleptic malignant syndrome, but the failure of the dantrolene, and then the degree of the stiffness, and the background of having him psychosis, this autism spectrum disorder with kind of like family that was changing from time to time, didn't give us like accurate story at the beginning, but then slowly seeing how he was able to actually relax with all the medications and everything was impressive. And when I saw the documentary with Celine Dion, specifically when there is a part in there that actually remember every single case with the patient when we give the IVIG and the Valium was mind blowing. Recently, this patient was being followed up at Hopkins for with the stiff neuro specialist group there. At some point, one of the PCPs kind of like decreased the Valium dose that he was, and then he got readmitted to a local ED for seizure-like activity that most likely was rigidity. So he was started back on the Valium, and he's doing fine right now. And so far, the paraneoplastic kind of like workup that he got has been negative. They resent the Mayo panel for Steve Person, and it came back positive for the gut, none of the other ones. But the trial of the volume, the response to the IVIG, and the constellation of symptoms kind of like make the diagnosis. It's something that I will never forget on my own illnesses, rigidity. And it's so important to kind of like, sometimes we also do the treatment before diagnosis, and then that's one of the best that we can do sometimes in these conditions. Yeah, I think that's my whole reflection.
I think that is incredibly nuanced and very wise reflection. I'm so glad that he ended up doing well. I'll just share with you something that dawned on me about stiff person syndrome, which is that it really requires the patient to communicate the sense of stiffness that they have. And I think that the only reason I imagine that you, Franco, saw such an extreme presentation is a hypothesis that this patient probably had been suffering from milder rigidity and stiffness for months, if not years. And only when the stiffness accelerated to a point where he could no longer relax his muscles was he able to present. And for those of you who are reading about this or will read about this condition, the classic presentation is usually a patient who has lower extremity predominant rigidity, culminating in falls, gait instability. And unlike Parkinsonism, it's usually bilateral, involving the lower extremities. And a very characteristic sign is what's called lumbar hyperlordosis, where a patient is essentially hyperextended backwards and they have hyperlordosis of their lumbar spine. The patients also experience an abnormal, and this is the spasm part, an abnormal startle response. So anything that alarms them or triggers them triggers and superimpose spasm. So you can imagine that these patients have this sneaky disease start to infiltrate their life. And with all these disabling symptoms, they often seek care, and most of them get under or misdiagnosed because the rigidity is subtle. And the symptoms overlap with psychiatric diseases, which unfortunately are often overlooked and neglected. And the patient's mental, emotional state is often attributed to their, the disease is often over-attributed to their mental emotional state, which understandably is also depleted because of the suffering that they incur. And so I could never imagine this case progressing this severity without the autism spectrum disorder in the background. I think the patient would have suffered too much, and his inability to communicate that is heartbreaking. And I think it probably culminated in it looking like something it should never look like, NMS or serotonin syndrome. And I'm humbled by that, Franco. And it really is amazing how when you have two diseases that are unrelated, stiff person syndrome and autism spectrum disorder, how they interact and mix with each other, they can result in a very unusual presentation of the latter. So that's my big picture reflection. I'll pass the mic to you to share yours, and then we'll learn from Hasha.
Lack of communication begets the need to use objective data to contextualize the patient's syndrome, because like in terms of contextualize, like offer time course that's more accurate, offer progression that potentially is more accurate. Like you wouldn't expect that degree of electrolyte abnormality to cause things in an acute manner. It's just like how important like the history really is in framing the problem, and without it we often rely on like imaging and labs to give us like a point abnormal and take that and run with it. But using that, like what's Franco was reflecting on, like going back to the case and putting it all together and trying to like reach back and reframe was what led to the understanding, like to go and even get the GAD65 antibody, which wasn't like, it shouldn't be on all of our initial workups for, yeah.
Hey team, Franco and Kara are going to keep me out of a job. I can see it already. Hats off to you both. That was awesome. And hats off to Manahil for scribing such a complicated case. Thank you, Manahil. Mike, to you, Khashar, for hopefully the longest teaching points of the year.
Thank you, everyone. This was a fantastic case. I definitely have to watch it again. And so let's see how we approach the patient. The most important thing, first of all, that I've learned here in CP Solvers over many sessions is that the most important thing you can do for a patient is framing the way you think about them. So let's frame this patient. First, we do a rapid response. We triage the patient. What is our first concern here? Here, hypoxia is the first thing that catches our eyes. Escalating oxygen requirements makes treatment be more important than diagnosing the patient. Here, we have to think about protecting their airways and assess for whether or not the patient requires intubation here. Other things we need to think about here were the rectus sheath hematoma, which was a learning point for me, especially in cases when we have extreme levels of rigidity. The muscles in the abdominal space can lead to rupture of the vasculature. And in these, this is usually seen in cases in patients with anticoagulations, but here the extreme rigidity can be a cause. We need to measure the abdominal pressure to be aware of the abdominal compartment syndrome if it happens. Now, after thinking about how we are going to respond to treatment of the patient, let's see what we can do with the symptoms. First, we have the neurologic component, perhaps the most obvious ones, rigidity. First, when we encounter the patient, we need to identify and describe the type of rigidity. How is it presenting in this patient? Especially here, one important point that was mentioned was the fixed posture of the left upper extremity, which was an interesting clue to the possible diagnosis here. After that, we need to think about where else could the neurologic component manifest itself. Our first reflexive thought was to think about the constipation that we were seeing, but putting it in the context of the patients in their psychiatric background, we can perhaps ignore the constipation and don't follow along an autonomic dysfunction path and focus more on what's happening with the muscles themselves. But a hallmark of muscle disease is weakness. We are not seeing that here. So what else is going on? Here we see a double presentation of two things together, stiffness and hyperthermia. Reflexive thinking should lead us here to a toxidrome, especially in the context of using drugs with known syndromic presentation. Specifically here, the most important concern at first was malignant catatonia. Let's discuss the fever. What is fever? Our first reflexive thought is infection, but there are 4 other things we need to think about. Hormones, hyperthyroid, hematologic like transfusion reactions, and hyperthermia itself. Hyperthermia points to a failure to dissipate heat. It's either due to extreme exposure, like we had a while back here in Iran, or failure to control. Here, you either have extreme generation of heat that can come with the rigidity itself, or drug reactions like serotonin syndrome that we are very familiar with, or failure to lose the heat due to failure of the heat loss mechanisms. Here we will see a failure to respond to Tylenol, but sometimes you don't have that, which is why we mentioned that you see stiffness, you see hyperthermia, go check the drugs. Go see what you can do for the patient. 4 things come up in the diagnostic plan here. Stiff person syndrome, serotonin syndrome, neuroleptic malignant syndrome, and malignant catatonia. Thinking about all of these requires us to understand the time course of the patient. Hypernatremia here was a clue to the time course. Unless there is something wrong with the kidneys, you don't see sodium getting to levels this high unless you have a problem with access to water, and especially if that problem is chronic. chronicity, given the high levels of sodium here, was the most likely cause, was the most likely presentation. So let's see how we can differentiate between these four. A lack of chronic responses argues against serotonin syndrome. Iron deficiency is often what we see in neuroleptic malignant syndrome. And malignant catatonia can be a prodrome or extension of another psychiatric disease, which can be explained by the psychiatric background here, especially in combination with the fixed posture of the left upper extremity. But the superimposed spasms was the key point here. This argues for antibody-mediated problems that can arise, and stiff person syndrome comes to the top of the diagnostic pattern here. This syndrome is specifically important that the patient can communicate this stiffness themselves, because it usually presents much earlier with bilateral lower extremity rigidity and gait instability, with abnormal startle response and lumbar hyperlordosis. But here, the lack of communication from the patient, given their psychiatric background, led to such an extreme presentation. I learned a lot. I need to rewatch the case again to learn more. Thank you all for the amazing discussion, and thank you, Frank, for bringing this case. This was amazing.
Oh, thank you, Franco. Me too, Khasher. Also, your ability to summarize the practical points of the practice of medicine and the theoretical framework with which we dissect a case. Beautiful. I wish you guys all the happiest of holidays, a happy winter solstice. And as the days get longer, that hopefully means more VMR time for us.
Yes. Bye, y'all.
Bye.